And I will pass the mic over to Dean Duran, and we'll get started.
Thank you, Veronica. Welcome, everyone. Bienvenidos, bienvenidas. I'm Cristina Duran. I'm the Dean of the Facundo Valdez School of Social Work. We are co-sponsoring, collaborating with the School of Education, the Counseling Department, as well as the Center for Teaching Excellence to welcome Dr. Bruce Trigg, who will be presenting tonight. I'll give you a little bit of more information about Dr. Trigg, his background and so forth. So we want to welcome everyone. I think I see some social work students here. So it's nice to see all of you here and everyone else from around the university and perhaps outside of the university as well. Let me see, Dean Mary Eric is the Dean of the School of Ed. I don't see her. Are you here, Dean Eric? I don't see you yet. I know I talked with her earlier, so I think she might join us shortly. And I don't think Dr. Jerry Glover is the chair of the counseling program in the School of Ed. I don't think I saw Dr. Glover. Okay. Anyway, I wanted to recognize leaders in the School of Ed as well for collaborating. You know, this came about, Lori Rudolph and all, Dr. Rudolph, who's also here, Dr. Rudolph, who's faculty in the counseling program, and I chatted about this. This came about last year sometime, Dr. Rudolph, I want to say, and Dr. Trigg, I understand, presented in your class, and was something that students really appreciated. Of course, Dr. Trigg is in New York now, but spent you know, a good deal of time in New Mexico, and so at that time we said, you know, let's see if there's a way that we can find to bring Dr. Trigg here to New Mexico and to New Mexico Highlands. And so it's really pretty exciting, you know, that here we are, we were able to make it happen and collaborate again with the School of Social Work, the School of Education, the counseling program, and also with the Center for Teaching Excellence. So welcome everyone again. So let me tell you a little bit about Dr. Trigg, and then I'll turn it over to you, Dr. Trigg, for your presentation. Again, this is a two-part series. We've got a presentation tonight, and then a week from tonight on Thursday at the same time, 5:30, is the second part of this presentation, which will focus more, my understanding, on treatment in related to this topic. A little bit about Dr. Trigg. Dr. Bruce Trigg is a pediatrician, a public health physician, and an addiction medicine consultant. He worked for the New Mexico Department of Health for 25 years, where he helped to implement one of the first statewide harm reduction programs in the US. Dr. Trigg is a medical director of the Sexually Transmitted Diseases Program in Albuquerque for 15 years. He helped establish a public health and methadone treatment program at the Bernalillo County Metropolitan Detention Center in Albuquerque. He was medical director of several I don't know how to pronounce that word, and methadone treatment programs. I know there's a way to pronounce that. I'll mess it up. In New Mexico, Dr. Trigg worked as a consultant on addiction treatment in several Asian countries, including India, Vietnam, and Burma. He currently lives in New York City and consults on addiction treatment for the New York City Department of Health and Mental Hygiene. Dr. Trigg is an advocate for evidence-based and harm reduction approaches for people who use drugs. He works to end the racialized war on drugs and the mass incarceration of people who use drugs. He was recently a volunteer physician at the Bellevue Hospital virtual clinic established in response to the COVID-19 pandemic. Dr. Trigg grew up in New York City and graduated from the City College of New York. He attended the George Washington University School of Medicine in Washington, D.C., and trained in pediatrics in New York and in New Mexico. Dr. Trigg served 3 years with the Indian Health Service in Crown Point, New Mexico, and in Zacatón, Arizona. So with that, Dr. Trigg, we extend to you a warm welcome. I'll turn it over to you at this point. And again, thank you so much for coming.
Thank you very much, Dr. Duran. Good evening, everyone. And I'd also like to thank the other deans, Dr. Ehrlich, Gardner, Glover, and of course, Dr. Rudolph for helping to arrange this. I feel like I'm back home in New Mexico. I'm feeling homesick. Um, Let us begin. Um, and again, if anyone has any questions or thoughts, please put them in the chat. I plan to speak for an hour, and then we'll take a short break, and then we'll have questions and discussion, which I'm especially looking forward to. But if there are a lot of questions during my speaking, it tends to throw me off, and I lose my thought. So let's see if we can get this to occupy that's good. All right. The opioid crisis is the other pandemic. I just added that title today because it really is the other pandemic. But it's impossible in this time. By the way, I have no conflicts of interest to declare. I'm not trying to sell you anything. And the goals of the talk were in the description. And these are the many the acronyms that I will try to not to define. But we can't discuss the opioid death and opioid use disorder epidemics without mentioning COVID, obviously. That's why we're having this conference on a Zoom instead of my speaking in person to you all. And really COVID has changed everything um, for the worst in some ways, and hopefully it will also change things for the better, because it has made it crystal clear that this is a quote from the Journal of the American Medical Association. It is a magnifying glass that has highlighted the larger pandemic of racial and ethnic disparities in health. And this is unmistakable and is something that must be looked at very carefully. So here are the New Mexico numbers as of today or yesterday. There have been 3,500 deaths from COVID, 181,000 cases. This is New Mexico. And the racial and ethnic disparities are very clear. Here you see all deaths with known race. This is the rate per 100,000 population. Here you see white New Mexicans, Latinx New Mexicans, Black New Mexicans, Asian, and this line is Indigenous New Mexicans. So the rate of deaths per 100,000 for Native Americans in New Mexico is counted 4 times the rate of the rest of the population. And nationally, this was actually on the news this morning, a very similar story, that the COVID has reduced the life expectancy of all Americans, but it's very disparate in how it's affected the races in the United States. White Americans have lost about a year of life expectancy. This is obviously on average for the whole population. Latinx have lost 3 years, 3 years for the whole population of Latinx people in the United States. 3 years of life expectancy has been lost already, and for Black Americans, about 2 years. This is unprecedented. This is unprecedented, probably since World War II, and before that, the great Spanish flu epidemic. But to be losing life expectancy is in a very, very wealthy country like the United States is unprecedented. So the COVID has really shown that we have big problems in the United States, in our healthcare system, in our public health system, and in our society in general. We were not prepared because we've had a deteriorating health status for years in the United States, weakened public health capacity. And I remember before I left New Mexico, there were 40% vacancies in the Department of Health under the Martinez administration. And a number of those, there's still, that hasn't, we're still not up to capacity in public health in New Mexico. Increasing economic inequality, racism that harms not only the direct victims, people of color, but erodes support for safety net programs that impact all Americans, and a wasteful healthcare system that is very profitable, but puts, unfortunately, profit too often over the health needs of the population. So yes, we have problems. So this is the other epidemic. So far, about almost 500,000 Americans have died from COVID. But since 1999, 750,000 people died of drug overdoses. 2 out of 3 drug overdoses in 2018 involved opioids. This is the numbers since, again, 1999, and endlessly increasing, increase in drug overdose deaths until 2018, when there was a dip. That was the first dip in all those years. And unfortunately, by 2019, that dip was eliminated. And the really sad news is that because of COVID, we now have estimated 81,000 drug overdose deaths. This is the largest increase we've had ever in overdose deaths. So this is directly related to COVID. Now, I want to point out the obvious. The United States didn't shut down. It wasn't seen as a national crisis when people were dying since 1999 of overdoses. And it's not to compare suffering. Obviously, COVID very much is a crisis and needs to be addressed that way, but that was not true of the overdose death crisis. And the frustration that my 2 hours of talking will be about is that there are evidence-based treatments that could have and should have and must still be applied to the crisis in overdose deaths. That would, if not end it, it would greatly diminish that. So let's talk about New Mexico. Here you see we're in red, and this is all the surrounding states in west of the Mississippi, with the exception of Arizona, have lower overdose death rates than New Mexico. This is in 2018. There were many years when I worked for the Department of Health when New Mexico had the highest overdose death rate in the United States, or was second or third. So essentially what's happened is the rest of the country has caught up to our great misfortune. But this is New Mexico compared with other states. This is, I showed you that there's 70,000 deaths in 2018, and now it's estimated to be 81,000. That's all overdose deaths. But about 2/3 nationally and in New Mexico are directly related to opioids. Okay, so opioids cause 2/3 of the overdose deaths. It affects every county in New Mexico, with the exception, I guess, of Union and Harding, which have extremely small populations. But here you see the US overdose death rate. This is, again, all overdose deaths of all causes. That is the sound of a snowplow on a Manhattan street. And it goes all night long. So here you see the US overdose death rate is 21 per 100,000. And here's the New Mexico average is 26. And here you see Rio Arriba County, which has 4 times the US and almost 4 times the New Mexico death rate, Rio Arriba County. So this is the overdose death rates, but the most deaths from overdoses occur in Bernalillo, which is of course the most populous county. So what are the causes of these opioid deaths? There were 338 in 2018, and 176 of them were from prescription opioids. So this is hydrocodone, oxycodone, morphine, medications that are prescribed for pain, but can also be involved and are also involved in overdoses. The next line is heroin, and that was about 130. Now, these are not exclusive. So about half of the prescription deaths also included heroin. So it's, in other words, they're separate, you know, the numbers are separate. And 105 involved synthetic opioids, and that means fentanyl. Now, I would point out that the prescription overdoses, this blue line, has been decreasing quite dramatically since 2014, and now is pretty much a plateau. The heroin deaths have decreased pretty steadily, but the only line that's going upward is the fentanyl line. What is fentanyl? Fentanyl is a pain medication that has very legitimate uses in medicine, mainly for cancer pain and post-surgical pain. But the fentanyl that's showing up in the drug supply, especially with heroin, but also with methamphetamine and cocaine, and even counterfeit pills that are sold on the street, for example, as oxycodone. In fact, it's simply, it's not simply, it's often includes or sometimes is completely replaced by fentanyl. So this fentanyl is illegally manufactured. It's believed that most of it comes from China and now from Mexico. And it's used to cut drugs, to add to the bulk, but also in some cases, we think that the drug dealers don't really know what they're dealing with. Drug dealers do not intend to kill their customers. It doesn't make any sense economically, but this medication, fentanyl, is 50 to 100 times stronger than morphine. So we are talking about an extremely tiny amount that can be deadly. And this is why it's so challenging and such an incredible danger to have this in the drug supply. Now, the only good thing I can say is that New Mexico seems to be less affected by the fentanyl epidemic than much of the United States. And we think it's because the main heroin supply in New Mexico is black tar heroin that comes from Mexico. And black tar doesn't lend itself to being cut with a white powder, which is what fentanyl is. So if you go to Seattle or New York City or San Francisco, almost all the heroin contains fentanyl. It's almost 100%. While in New Mexico, it's growing in the amount, but it doesn't seem to be as much of a problem yet. That could obviously change very rapidly, okay? So fentanyl is what's driving the overdose death epidemic nationally and to a certain degree in New Mexico as well. This is from the Department of Health, which has excellent data on the overdose deaths and drug epidemiology in New Mexico. So again, 72% of the deaths involved prescription opioids, 42% also involved heroin. Two out of 3 drug overdose deaths involved an opioid. The methamphetamine death rate almost tripled from 2013 to 2018. Sometimes that's because, not sometimes, often it's because fentanyl is being added to methamphetamine. If someone is taking methamphetamine and doesn't use opioids, they have no tolerance at all to opioids, and even less fentanyl contamination will lead to a fatal overdose. It's super, super dangerous. So many people have died from overdoses in the United States that it has contributed to a decline in life expectancy. I already referred to the decline in life expectancy from COVID, but US life expectancy has been going down from before the COVID epidemic. This, in fact, here we see the US compared with Japan, Germany, United Kingdom, France, Italy, and Canada. This makes up the G7, seven very wealthy democratic nations. And the US was in the middle of the group until around 1980 when we started falling behind. So the United States problem with life expectancy predates COVID. And a certain amount of it is due to, not all of it, but a certain amount of it. Okay, the other thing is, here you see the other G6 countries, right? And the average US life expectancy below the average for all of those countries. However, Hispanics, however, there's a racial difference, and Blacks and Native Americans have a greater gap in life expectancy compared with white Americans and Hispanic Americans. So two economists, I think they were at Princeton, in 2015 came up with a concept, they call it diseases of despair. And they were looking specifically at decreasing life expectancy among white working class males, especially in the middle part of the United States. And they came up with this term, diseases of despair, and they showed that deaths due to suicide, alcohol, and drug overdoses was contributing to the decrease in life expectancy. But the reality is that it doesn't only affect white working class males, it affects all Americans. Here you see alcohol deaths in New Mexico. Again, the US number, the New Mexico number, and some counties with extremely high rates of alcohol-related deaths. McKinley, Rio Arriba, San Juan, Cibola. Suicide, again, New Mexico is really horribly affected. Here's the US rate of suicide, the New Mexico rate, and again, some counties with 2-3 times the rate, Hidalgo County. So diseases of despair are not new to New Mexico, but it's an important way, I think, for us to think about why we're so far behind. So the other thing is that welcome everybody, all these people. I assume maybe people are leaving. I don't know if those sounds are coming or going. There's a term called syndemics. You all know what an epidemic is. It's an increase in the rate of a disease that's higher than normal. It's called a pandemic if it includes a broad part of society, usually internationally. So COVID is clearly a pandemic, just like the overdose death epidemic is actually international and is therefore meets the criteria of a pandemic. But syndemics are other epidemics that are related. They have a common cause or common causality. So the HIV epidemic is related to drug use because injecting drug use is a major route of transmission of HIV. So in New Mexico, this is new cases of, no, I'm sorry, this is everyone living with HIV. No, I take it back. It's new HIV diagnoses in New Mexico. And you see here that 5% are directly related, are considered to be caused by injecting drug use, but another 9% are men who have sex with men who also inject drugs. So what that means is that the amount spread by injecting is between 5.9 and 14, because some of these, we can't tell if someone who has high risk sex and also is using needles, we can't tell how they acquired the infection. But so the rate is considered 5% to 14%. But for females, new cases, 1/3 of them involved IV drug use. 1/3 of new cases of HIV. So this is a syndemic because it's related to sharing of needles. Hepatitis C, the main cause of that, in fact, almost all the cause of hepatitis C is needles, is sharing needles and equipment related to injecting. There was and here you see new cases, they're actually baby boomers, because injecting drugs was quite common in the 60s and 70s. So baby boomers are all supposed to be screened for hepatitis C. So many people have hepatitis C from the baby boomer generation that it's considered a public health recommendation to screen all baby boomers. But what we're seeing now is there's also a second peak coming up in the more recent drug use epidemic. From 2010, you see it started to rise. So that's another syndemic related to drug use. And finally, syphilis, congenital syphilis, it was once an extremely rare event, and that's also increasing quite noticeably, and that is felt to be related to women who are pregnant, of course, who are often using especially methamphetamine and opioids, and are therefore getting less, well, for one thing, being exposed to syphilis, perhaps from selling sex for drugs, or for money, or for survival, and then not getting adequate prenatal care for many reasons. And we are seeing an increase in congenital syphilis. There's an 80% chance of a mother passing syphilis to her unborn baby, and about 60% of those newborns will be affected, and in fact, about half of them will have a risk of death. It's a cause of prenatal mortality. More babies being born with syphilis, blame meth and opioids. And I'm sorry to say, all of this is the tip of the iceberg, because about 2.5 million Americans are believed to have opioid use disorder related to pain medicine and treatment of pain medicine with chronic opioids. So the twin epidemics are the overdose deaths, and then the large number of people who have opioid use disorder. And again, many of them have acquired it from medications that were prescribed by the doctors or medical providers to try to deal with chronic pain. So what is the public health approach to this pandemic and the syndemics? Well, first of all, we'd like to prevent people from developing opioid use disorder. Second, we'd like to reduce people with that problem by treating their addiction. And third, we'd like to reverse overdoses with naloxone and with other harm reduction means to prevent overdoses. So it's basically a three-legged stool to prevent, reduce, and reverse overdoses. So iatrogenesis is an interesting Latin word, and it means inadvertent and preventable induction of disease by treatment or procedures of a physician or a surgeon. Well, that's, we would of course include any medical provider. So this means a disease that's caused by the medical care system. And unfortunately, in large part, this opioid use disorder epidemic. Now, let me explain. We used to use, and I will interchangeably still be using the term addiction, but the technical term now is opioid use disorder for opioid addiction, methamphetamine use disorder for meth addiction, and in general, we would call them substance use disorders. So part of the reason for changing the language is to deal with the stigma that accompanies certain words like addiction and addict, especially. So these are words we're trying to get away from to destigmatize people who use drugs and to make it more accessible for them to receive adequate treatment. It's a sad story, but I've worked in many emergency rooms in my training where someone who was known to be using drugs was mistreated and labeled, oh, that's just a junkie, that's an addict, let them wait. Let's have the lowest, the newest medical student go in and examine them. So it's that kind of stigma that pervades this field, and I'll be addressing more of that in the next couple of days. But we know that that there was a very effective plan to sell OxyContin to the public by using medical practitioners and convincing them that this was a safe medicine to use, even though the company knew very well that that was false information. So this is the famous scandal that's still being worked out, where Purdue, the company that manufactured it, they've recently declared bankruptcy, and they will pay billions of dollars, but none of their executives at this point has been charged with criminal activity. Try to figure out why. Try to figure out why that is. So Purdue, the company that made OxyContin, figured out how to very effectively market OxyContin through physicians by convincing them. And I actually remember going to medical meetings where someone from that who was either paid by the company and said they were representing them, or someone who may not have actually declared their financial interest, said that fewer than 1% of patients who took OxyContin would become addicted. By 1999, mind you, before 750,000 Americans died, by 1999, Purdue knew that 13% of people who were getting OxyContin for headaches were becoming addicted. So it took a really long time for us to address this. Purdue even gave physicians coupons for free prescriptions for OxyContin, and 34,000 were redeemed. So this was just a huge scam and scandal, and it involved the medical profession. In fact, the global consumption in the United States of hydrocodone is 99%. The United States consumes 99% of the hydrocodone, a powerful pain medication in the world, an opioid, and consumes 83% of the oxycodone. So either the United States Americans are in huge amount of pain compared with the rest of the world, or unfortunately, the reality is that it's been way overprescribed and misprescribed by physicians, because these are prescription medicines. People, don't get them on their own, although people often obtain them from friends and relatives or buy them, purchase them. But the source ultimately is from doctors and nurse practitioners and physician assistants. So much use of those medicines that the US overdose death rate is way out of proportion to every other country. Portugal has 6 deaths per million population from drug-induced deaths, and the United States has 185. Now, unfortunately, there's still a very unhealthy relationship between large pharmaceutical companies, what we call big pharma, and the doctors mostly who prescribe these medications. And as recently as 2018, a study showed that half the payments to doctors were made to promote fentanyl, a synthetic opioid. Now, I already said that fentanyl does have legitimate purposes in medicine, but you don't need a pharmaceutical salesperson to convince you to use fentanyl for someone with surgical or pain or cancer. So the reason they go and advertise and wine and dine, in many cases, physicians, is to get them to prescribe it outside of cancer pain and outside of surgical treatment. So this kind of unhealthy thing is still going on, and it is really should be unacceptable. Now, one thing that has been in New Mexico and all over the United States to decrease this misprescribing and overprescribing has been to what's called prescription monitoring programs, or I think in Mexico, yeah, in some cases it's called prescription drug monitoring program. So this is run out of the New Mexico Board of Pharmacy, and it requires that every prescribed medicine that's dispensed by a pharmacy has to be put into a database, and this is only for controlled substances. So it would include opioids, benzodiazepines, other medications that that we call narcotics that affect mind altering, and this has been quite effective. It's actually considerably in states that have looked at it. In New York, for example, it reduced by 75% the number of individuals who were seeking multiple providers for the same drugs. We call that doctor shopping. In Kentucky, it increased the prescriptions for treating opioid use dependence because people were showing up at the pharmacy asking for, with multiple prescriptions, and they were being directed to get treatment for their opioid use disorder. But unfortunately, when this came out a few years ago, 2 out of 3 providers in New Mexico were not checking the prescription monitoring program. So in some states, it's mandatory that this be checked, and New Mexico has not yet achieved that. But it has, as I pointed out earlier, the number of deaths related only to prescription medicines is plateauing to a certain degree. So it has decreased. It's been partially effective. So let's talk about the biology of addiction. Okay, we have opioid receptors in the brain. We have evolved as a species over millions of years to reward certain behaviors that keep us healthy and keep the species propagating. So for example, if you're thirsty and you drink water, right, your brain will generate what we call I'm lucky what they're called, endorphins, right? Endorphins are natural opioids that we generate ourselves, and they will fill these receptors, and the result is that dopamine is released. Dopamine is the feel-good neurotransmitter. So if you're thirsty and you drink, you generate some endorphins that make you feel good. If you're hungry and you eat, the same thing happens. If you have sex, it generates endorphins and it makes you feel good. If sex or eating were unpleasant things to do, we wouldn't be around as a species. So this is something that's intimately involved with the evolution of people. Thousands of years ago, people figured out that the sap from the pod of this lovely flower called the poppy, called the opium poppy, made them feel very good. It took away their perception of pain. It also stopped diarrhea, which was probably a very helpful thing then, just like it is now. But it made you feel really good. Even if you weren't in pain, it made you feel euphoric, happy. So it turns out that the molecule in the pod of this flower is an opioid, and it fits those receptors in the brain. So it's just a coincidence, but it actually has led to the propagation of this poppy. I mean, in terms of evolution, the goal of the poppy plant is to keep propagating. And the fact that it makes people feel really good has guaranteed that the opium poppy has always been grown and will always be grown. So it's an interesting story. Here you see the natural rewards by measuring dopamine levels of food and sex. And I always like to point out that sex actually gives you more dopamine pleasure than food, which again is good for us as a species. Now, the receptors for opioids are not evenly distributed in the brain. They are concentrated in certain areas. This is the reward and pleasure part of the brain. We call this the primitive brain. So there's lots of opioid receptors, again, that reward you and make you feel good when you do certain things. But there are also opioid receptors in the frontal lobes of the brain, in the cerebrum. And this is the part of the brain that relates to higher reasoning, to how we think, and it determines our behaviors. So think about it. The opioids don't just make us feel good, it also affects our thinking and our behavior. And this is why there's so much misunderstanding and fear, and I think stigma around addiction. Because if someone has a sick spleen, people don't fear and dislike them. But if someone is acting very strange and is doing things that we think make no sense or that are counter to their own well-being and to the well-being of their family and of their community, we start to fear and mistrust these people. But actually, it's because these receptors in the thinking part of their brain has been impacted by this condition or disease. So it's very interesting, but that is the nature of addiction and part of why it's so difficult to address. Now, just taking a drug doesn't make you addicted. It doesn't mean that you have a problem, because many more people have tried heroin or have tried methamphetamine or have tried cocaine than actually become negatively impacted by it. But a certain percent of people do. And we have what's called the DSM-5, which I think is used in all the disciplines who are involved in this conference. The DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, and this is the 5th edition. So how does it define substance use disorder? So again, notice it doesn't say addiction, it's called substance use disorder. It says it goes from no diagnosis to a mild SUD to a moderate to a severe. So there are just 11 criteria. Are you using a larger amount for longer periods of time than intended? So this is classic, right? I only was going to have one beer. I decided, I had to work that night. I was just going to have one beer with my friends, and you wind up drinking 20 beers. Well, that clearly meets this criteria of substance use disorder. Everyone says you need to quit or cut down, and you tried numerous times and you can't do it. That's another criteria. Excessive time spent taking the drug. Instead of doing going fishing, which you used to love to do, now you're spending all your time trying to get oxycodone pills so you can deal with your withdrawal. Failure to fulfill major obligations. You're not going to work. You're not going to classes. Continued use despite problems. You know that it's causing you harm. You know that it's making your spouse miserable. You know that your children are acting out because of this, but you can't stop it. Important activities given up, recurrent use in physically hazardous situations. You're driving under the influence. You continued use despite problems. Tolerance means you need more of it to have the same effect. I used to just have one beer, one martini, and I felt fine. And now I need 4 martinis to feel the same way. Withdrawal symptoms, especially with opioids, you don't, if you don't get your heroin in 12 hours, you start being quite ill. And cravings, even if you haven't used for a few days, you're still having cravings. So if you meet 4 or 5 of these criteria, you have what we call moderate substance use disorder. And if you have 6 or more, it's severe. One way to think about it is all of these criteria fit into 3 categories. It's loss of control, compulsive use, you can't control it, and continued use despite negative consequences. So these are the 3 the 3 groups of criteria. And if someone meets these criteria, they have methamphetamine use disorder, alcohol use disorder, or opioid use disorder. So let's talk about a real human being, a young woman, very, very real person who was written up in the New York Times a few years ago. And she was 24 years old and she was shooting heroin for 3 years. And she'd been in and out of detox 8 times. This is not unusual. I've met with groups of people and said, how many of you have been in detox? 5 times, and all the hands went up, or almost all the hands. So how many of you have been in it 10 times? And many hands shut up. How many of you have had 15 episodes? And several hands shut up. So something is wrong if we're not, what is the saying? Doing the same thing over again and expecting a different result is a definition of that something's out of whack. Miss Harvey had been an honor student. She developed anorexia. Alcohol was next. And by 21, she was hooked on heroin. Many people who do develop substance use disorders have other mental health problems. We call this co-occurring disorders. And the number is about 50%. So this young woman had anorexia, definitely a mental health diagnosis. And she tried alcohol, and by 21, she was using heroin. She was shooting up a staggering number of times a day, perhaps as many as 15, heroin, cocaine, and fentanyl. She overdosed 5 times. Now, this also shows that many patients, many people are not exclusively using one drug. Polydrug use is really the norm rather than the exception. People are using different substances, and sometimes it often doesn't make sense from a pharmacological sense, because heroin is a downer and cocaine is a stimulant. Well, are you addicted to stimulants or are you addicted to downers? And the reality is, for many people, they prefer, or they'll use any drug they can to alter their state of consciousness. They're sort of, people call them, they're yo-yos. They'll be stimulated, then they want to be down. But people are not often, now some people only use one class of drugs, but it's very common for people to be polysubstance users. And that's a whole other interesting conversation. Now, she entered this detox center, a rehab center, and 4 days later she checked out. and she went back to her friends and drugs, developing an abscess, probably from unclean needles. 2 weeks later, she was back in detox. She stayed and she entered a 30-day program. And finally, her comment to the New York Times reporter was, tell your children you love them because it might be the last thing you say to them. Because this young woman has an extremely high risk of dying, because if there's fentanyl, and in Massachusetts, virtually all the heroin has fentanyl. If there's a grain extra of fentanyl when she injects, she's at very high risk of dying. So this is a very sad story, but it points out the deficiencies in our approach to people with opioid use disorder in the United States, because she should have been told on day one that we have effective treatments that are evidence-based, that are used all over the world, that would dramatically decrease your chance of death and dramatically increase your chance of having a normal, healthy life. And this woman was never told that. So I hope that from listening to me drone on for 2 hours, that everyone on this call will not be in the position of seeing anyone like this young woman and not telling her there is hope and there are treatments that should be available to you. And then our task is to help people get this treatment. This is called medication for addiction treatment, or MAT. It's pharmacotherapy, a medicine combined with psychosocial support, and that is the way we can treat addiction. And no one ever offered this to this young woman. It's very possible to go through this over and over again and never meet anyone that will explain it to you. MAT is consistent with a medical model of how we treat chronic diseases. How do we treat diabetes? We offer a medication like insulin, right, that lowers your blood sugar, and we work with the person to address other things in their life that affect their diabetes, their diet, their eye health, their foot health, right? But the mainstay of treatment is insulin, right? Insulin or metformin, right? The mainstay is medicine. How long do we continue insulin? How long do we continue metformin? For most people, it's long-term. And for some people, it's for the rest of their life. And no one gets a hard time about it. No one gets really bent out of shape because this person we love is taking insulin. No one shouts at them and threatens to throw them out of the house. But that happens to people who are being treated with methadone and Suboxone all the time. What if you have high blood pressure? You stay on high blood pressure medicine. Does everyone in the family, do people in the family go, I hate Lipitor. It drives me crazy that you're on Lipitor. It shows that you're weak and you're still hypertensive, and I want you to stop your Lipitor. So the way we treat all these chronic diseases is the way we should be treating opioid use disorder. All it does is replaces a legal long-acting opioid called Suboxone or methadone in order to prevent withdrawal, minimize craving, and block the ability to get high if you use heroin or another illicit opioid. It only does 3 things, but those 3 things nail the addiction. The day you start your Suboxone or the day you start your methadone, you are no longer addicted by any definition. And we'll talk about that more. We should treat opioid use disorder the way we treat other chronic diseases. Now, this is a study that will never be repeated, and it's an old one. It's from 2001. And look, they're referring to people as heroin addicts. I already said that's really an unacceptable, it's the A word. We should never call anyone an addict. But in 2001, that was accepted. So anyway, they followed 600 heroin people with heroin addiction, right? Opioid use disorder, who were injecting heroin in Los Angeles. They followed them for 33 years, which is astounding. They actually were able to track down almost all of the people 33 years later. This was a study out of UCLA. And what they found was 33 years later, half the people were dead. Now, I went to my 50th high school reunion just a few months ago, pre-COVID, and a few of my classmates had passed away. But had half of them passed away, that would have been unbelievable. That would have been if I lived in Afghanistan or Iraq. 33% of people in the United States don't normally die in 33 years, but half of these people were dead. So we're talking about a deadly disease. And of the ones who are still alive, the other 50%, about 60%, about 56% of them said they weren't using heroin anymore, which is very, very good news. But about 20% were still using 33 years later. 14% of them were incarcerated because the natural history in the United States of untreated opioid use disorder is death, premature death, or spending a good deal of your life in and out of jails and prisons. And 10% refused to be tested. Well, I can only assume that they refused to be tested. Why? Because they were still using. So this is, on one hand, this is very discouraging news, right? If you use heroin and 33 years later, you're tracked down, you have a 50% chance of death. And then of those people, about half of them are still using. On the other hand, it shows us that this is truly a chronic disease and requires chronic treatment. So the goals of MAT are to reduce mortality, reduce transmission of blood-borne viruses like hepatitis C and HIV, to improve people's general health and well-being. We want people to be healthy and happy. And part of that is reducing drug-related crime. If you have a drug habit, you have to come up with money, and usually it's more money than you can earn legally, so people turn to crime. And finally, it reduces misuse of opioids. Well, those sound like very reasonable goals. And can we achieve these goals? There are 3 medicines that the Food and Drug Administration has approved for treatment of opioid use disorder in the United States. Methadone, since 1973, buprenorphine, which is the active ingredient in what's commonly called Suboxone. The problem is that buprenorphine is also mixed with naloxone, and it becomes a tongue twister to call it buprenorphine / naloxone. So that's why most of my patients prefer just to call it Suboxone. But the reality is that Suboxone is just a brand name. It's like calling all soda pop Pepsi or Coke. It's what people call it, but in fact, it's just a brand name. But it doesn't really matter what you call it. But the alternative, so we have 2 preferred treatments, and we have 1 alternative treatment, which is naltrexone. And I'll talk about all these treatments over the next couple of days. This is a pharmacology slide, and it shows what's called dose and effect. Dose and response, dose and response. So this shows that as the dose goes up, the x-axis is the dose. So here you go from a low dose to a high dose. And this is the effect. So you have down here a little effect and down here a lot of effect. So let's say we're looking at what we call an agonist, which means that the medication fills the receptors and has a full response. So that's called an agonist. So the agonists are all the drugs that are opioids that can be misused but that are also prescribed for pain management. So it includes oxycodone, hydrocodone, Dilaudid, hydromorphone. It includes heroin, and it includes methadone. All those medications are called agonists. And the more you take, the more of an effect you get. So let's say we're talking about euphoria, right? How happy does it make you? If you take a little bit of heroin or methadone, it'll make you mildly euphoric. But if you take a whole lot, it'll make you very euphoric. And that's true um, if you're measuring euphoria. But all opioids decrease the respiratory rate. So if you take a little bit of heroin or methadone, it'll slow down your respiratory rate. But if you take a lot, it will slow it down. And eventually the endpoint is you stop breathing. So that is the major cause of overdose deaths from opioids. It's you stop breathing if you take too much, okay? And even a little fentanyl will cause people to stop breathing. So these are called agonists, and they all have this profile that a little bit does a little bit of, has a little bit of response, and a lot has a large response. On the other hand, buprenorphine or Suboxone, or the active ingredient in Suboxone, which is buprenorphine, is what we call a partial agonist, because at lower levels of taking it, you do get more of a response. But once you reach a certain point, it plateaus off. We call this the ceiling effect. So if you take a little Suboxone, you'll slow up your breathing rate. But if you take a whole bottle of it, you still won't stop breathing. It has a plateau. So therefore, for all practical purposes, you can't overdose on buprenorphine. So this is an extremely important characteristic of this molecule. I will say that children, infants and toddlers, and even small children, unfortunately, will stop breathing if they get their hands on buprenorphine. So if a child accidentally gets into their parents' buprenorphine, Suboxone, they do risk, and there have been tragic deaths. But adults can't overdose on it the way they can methadone and heroin. And then finally, we have naltrexone, which is what we call an antagonist. It has no effect at the receptors. It doesn't do anything. It just sits there, blocking the ability to get high, blocking the receptors from accepting methadone or buprenorphine or any other opioid. So this is the only pharmacology slide I'm going to show, but I will be referring to it because it's extremely important. The first medication for treatment of opioid addiction in the world was methadone, which was a molecule that the German scientists came up with during the Nazi period. And the reason they were told to develop this synthetic opioid was that they knew that it was very likely that the war they were planning, and they were certainly planning a war, would likely cut them off from the supplies of opium, which were mainly grown in those days in Turkey. And they knew that if they couldn't have opium, they wouldn't have morphine. And you can't fight a war without morphine, because people on the battlefield need immediate and extreme pain relief. So the German scientists came up with this synthetic opioid called methadone, but they actually never used it. After World War II, the US, as reparations, partial reparations, received the product of the German laboratories, and they received this new molecule called methadone, which was a long-acting opioid, and no one had ever seen a long-acting opioid before. So they started to play with it. Can we use it for pain? And in fact, methadone to this day is a very effective pain medication, very effective, and is especially useful for pain related to cancer, chronic pain related to cancer. But these two scientists, Dr. Dole and Niswander, two doctors and researchers at Rockefeller University in New York City, were using methadone. They tried to use it for withdrawal from opioids. And what they found was people who were given this methadone became very stable. And not only did it take away their withdrawal, but they started acting like normal people. They were able to work and go to school and function completely normally as long as they were getting some methadone on a daily basis. So this was an incredible revolution, and they developed methadone, and the timing couldn't have been better, because at that time in the mid 1960s, a lot of soldiers were coming back, US soldiers from Vietnam, who had been using very high grade heroin while they were in Vietnam, and they were addicted to heroin when they came back. Now, the interesting story is that the vast majority of them, even though they were addicted in Vietnam, once they came back to the United States and their entire situation was different. They were back with their families, they were back with people who loved them, they weren't risking their lives every day. Most of them were actually able to walk away from the addiction, which is very, very interesting. It shows there, in fact, that the environment people are in plays a significant role in addiction. On the other hand, some of them were not able to walk away from the addiction. And, you know, when I was seeing patients in Albuquerque 4 years ago, some of them were clearly, and they were very upfront about it, had become addicted as teenage, 18, 19-year-olds in the US Army in Vietnam. And some of those people, that's where they developed their addiction, and they were still in treatment. Fortunately, they were in treatment. Some of them probably were not. So anyway, this came about at a very important time, and immediately this was recognized as an incredibly important medicine. And New York City developed clinics, and New Mexico actually had one of the first methadone clinics out of New York City in the early 1970s. It was the first treatment for opioid use disorder that was approved. And however, because it was a full agonist and people could overdose from it, they decided they needed to be extremely cautious with it for obvious reasons. And they decided that it could only be dispensed in special clinics that were called methadone clinics in those days. Now we call them OTPs, opioid treatment programs. And it came with a lot of federal rules and state rules on top of that, and a huge amount of regulation. And while it made sense, I think, 50, 60 years ago, unfortunately, it's very hard to change government regs once they become established. And for 50, 60 years now, we've still had essentially the same rules, even though other countries that have used methadone also for decades have very different rules, and in many cases are less stringent with it. And it's really taken until the COVID pandemic, for some of these rules to be changed. So the rules around methadone are that you have to go to a special clinic, and at the beginning you have to go 6 days a week, and you have to be directly observed taking the medication. But methadone remains the gold standard of treatment for opioid use disorder. Well, what exactly does methadone do? It does what I said earlier. It takes away withdrawal symptoms, it diminishes craving, and if you are on the right dose of methadone, on the proper dose, if you shoot heroin on top of it, or you take an oxycodone, you do not feel it. So we call it a blocking dose. So the goal of methadone is not to have people on as little as possible, it's to have them on the right dose that enables them to have a healthy, happy life. And also, if they were to relapse, they would not feel heroin. So if they're doing well, and on Saturday night they run into their old friends and they decide to try using heroin, which does happen, if they are taking their methadone every day, they will not feel the heroin. They will not feel it. So this is very important. So I said It comes with all these regs. At the beginning, you have to go 6 days a week to the clinic and get directly observed treatment. And you're tested um, generally once a month. There's a random urine test. And if it contains any illegal drugs in it, then then you're not allowed to get take-home doses. In other words, your take-home privileges, they call it, are revoked, and you have to go back in many cases to everyday dosing. And this is a problem because people often will continue to use other illegal drugs. Well, why is that? It's complicated, but mind you, this methadone is only treating opioid use disorder. It doesn't treat, no one says that methadone treats methamphetamine use disorder. No one says that it takes away your desire or your addiction in some cases to use cannabis. So essentially, we're holding the treatment of opioid use disorder hostage to the fact that people have other untreated, right, addictions that the methadone doesn't treat. So I always say this is like saying essentially that I'm treating you for cancer, but oh, now you have diabetes, so you're no longer a good cancer patient. You know, I can't keep giving you your cancer medications because now you have diabetes. I mean, it doesn't make sense, right? We're not treating other disorders. We're only treating the opioid use disorder. So why do you punish people for having other untreated problems? But this is the contradiction that pervades treatment of substance use in the United States. Now, and eventually, if you do have negative urines, notice I didn't say clean urines, negative urines, if they're negative for other drugs, then within a year you can get 2 weeks of take home. So that's quite reasonable. It's hard to go to work every day or to take care of your kids every day and to meet your other responsibilities if you have to line up 6 days a week in most cases at a clinic. And yet that's very common, unfortunately. So here's an example of a nurse or a pharmacist who directly observes. Person comes up to the window every single day, or eventually it's spread out a little bit, and they show their ID and they look them up in the computer and they say, "How you doing?" and they take their dose of methadone. New Mexico has 20, I counted earlier, 13, 14, 15, 16, 17, 18, 19, 20, 21, 23 opioid treatment programs, a dramatic increase over the last 10 years. There wasn't one in Lordsburg when I was in New Mexico. There wasn't one in, now there was one in Las Vegas that had shut down. So it looks like it's reopened. Does anyone know? Farmington, Roswell, Albuquerque has 13 treatment centers. So methadone is widely dispersed, but there are places in New Mexico where you have to drive quite a distance to Roswell, Farmington. I had patients who drove 2.5 hours to get to my clinics in Albuquerque and Santa Fe. So that is a lot of driving to do 6 days a week. Now, under COVID, they have allowed states that have declared emergencies, which almost every state has done, to now let people have 14 days of methadone at a time, even if they are not stable. In other words, even if they're still using other drugs, or they're not coming every day, or they're not meeting regularly with their counselor, they're allowing people the leeway to get 14 days. And if you are a stable patient, you can get 28 days of methadone. This is the first time in 50 years that the rules have changed about take-home methadone significantly in the United States. And you know what? People are doing very well, and there has not been a rash of people selling methadone or overdoses related that we know of. I'm sure it's being looked at closely. But if this holds up, then this is going to be a very strong argument for relaxing the rules around methadone in the future. But this is going to be a big debate once COVID's over. Now,
Dr.
how
Trigg,
does methadone? Yeah, go ahead.
we're at the 15-minute mark,
Okay.
15 to 7. New
Thank you
Mexico
for
time.
letting me know.
Yeah, no problem.
Yeah. Okay. So, so again, there was a politician who is otherwise very progressive in Albuquerque, who was actually a neighbor of mine, who I had great respect for and still do. But I remember telling him that I was working in the methadone field, and his response was, "Methadone, I hate methadone. It's horrible. It's worse than heroin." Well, he was a well-meaning person, but he knew nothing about treatment of opioid use disorder. And unfortunately, people sometimes get there, they are convinced that they know about things they really don't know about. So it is not the same as heroin. It is very different from heroin. When you use heroin, it takes 10 seconds for it to flood your brain with euphoria. In 10 seconds, you are high as a kite. If you take methadone, you don't feel anything for 30 minutes. And the peak of the methadone is 3 hours. 3 hours. So don't tell me, please don't tell me that you think people take methadone just to get high, because that's not how people get high. I like to tease my friends that there would be no martini bars in New Mexico or in New York City if you went into the bar and ordered a martini and you had to wait 3 hours to feel it. That's not how you get high. That's not why you drink. You don't drink a beer and wait 3 hours for it to feel the full effect. So no, people, may get a buzz especially if they're not regular methadone users, but it is not ever going to replace heroin because that's not the way you get high. Also, heroin only lasts 4 to 6 hours. You spend your whole life getting high, then feeling normal, and then you need to go get money in order to get more heroin because you know you're going to be sick in a short period of time. Methadone lasts 24 to 36 hours. You take it once a day. You take it in the morning and you're fine until the next morning. If you are high during that time, then your dose is too high. If you get sick in the 24 hours, then your dose is too low. So that's why we have doctors at every methadone clinic who adjust people's doses. The goal is not to be high and not to be sick. It's just to feel normal for 24 hours. If you miss the next day's dose of methadone, you are not sick because half of the dose is still in your body 24 hours later. So you will not be in withdrawal 24 hours later. You probably won't be into withdrawal for 2 days. So people, somehow, unfortunately, patients are not often educated properly, and they think, oh, if I don't get my dose the next morning, I'm going to have to use heroin because otherwise I'm going to be sick. But the reality is that they do have quite a bit of leeway. We don't want people missing doses, but sometimes there's a snowstorm or your car doesn't work and you don't have to panic. You'll be fine for 2 days. The other thing is, how do you use methadone? You take it orally. You've just eliminated the risk of hepatitis B, hepatitis C, HIV, and heart valve infections and skin infections because you're not injecting it, you're not snorting it, you're not smoking it, taking it orally. So this is nothing at all like heroin. It's a very, very different drug. Methadone is the most studied medicine in the history of Western medicine. There are over 1,500 published papers, scientific studies that have been done over 50 years on methadone. We know that it reduces the death rate 4 to 5-fold. It reduces drug use, not just heroin use, it reduces all drug use. It reduces criminal activity. It enables people to, again, be mothers, fathers, workers, students, have normal lives, reduces the spread of HIV, and not most important, but it keeps people in treatment. For any chronic disease, you want people to stay in treatment. So this was a study done, in fact, in New York City, where people who were in treatment versus out of treatment were less likely to become infected with HIV. Okay, out of treatment, they were this much risk, 30% of them were getting infected, and in treatment, it was more like 15%. That's a very dramatic improvement in a potentially deadly disease. This is why I call methadone and buprenorphine anti-crime pills. These were 6 different methadone maintenance treatment programs. And it showed people's days of crime before they were in treatment and after they were in treatment. So in this clinic, the average was people were having days of crime 250 days a year. They were involved in criminal activity. And once they were on methadone, on average, it was less than 25 days. So this is what I call an anti-crime pill. There's no law you could possibly pass, no risk, no threat of punishment that will decrease crime like putting someone on methadone, like someone being on treatment. Okay, so now that I finished methadone, this is probably a good place to break. And next week, we'll cover buprenorphine, the medicine I really am most interested in talking about, because methadone can only be dispensed to this day out of these special clinics, right? Now, it's interesting. That's if you're treating opioid use disorder. If you're treating pain, any licensed medical provider can prescribe methadone for pain. But if that prescriber is actually treating addiction, then that prescriber is risking losing their license and even going to prison. So it's the rules are very, very clear about how methadone can be prescribed. But buprenorphine or Suboxone was developed in 2002. It was first approved for treatment as an outpatient in a primary care setting. So it's a very different mode of prescription, right? It's a very different way of treating opioid use disorder. Instead of going to a clinic that's specifically for opioid use disorder, you're going to the same clinic where people are getting prenatal care and immunizations, right? And being treated for other chronic or acute diseases. So the idea was that it would take away the stigma and the labeling for people, and it would make treatment more acceptable. So I think on that note, I will end. And why don't we take a short break? How many minutes should we give people?
Well, this event is scheduled to be wrapping up at 7, and we've got about 6 minutes till 7. So if you want to, we can just kind of power through, and there's a few questions in the chat. How does that sound?
That is absolutely fine. Yeah.
Okay.
So we didn't leave enough time for questions. So next week I will make a point of doing that.
Yeah, we can leave a more Q&A kind of discussion next week. That sounds good. There are a few questions in the chat, such as what efforts are being made to educate members of the justice system, prosecutors, judges, and so on.
Yes. Okay. Yeah, that's a great question, an extremely important one. And I actually will go into it in some depth next week.
Next week. Okay, excellent.
But let me just say that where should we make evidence-based treatment available? We should make it available where people are. So it's, yes, some people will walk into a methadone clinic. Some people will make an appointment with a primary care provider, but other people wind up in the emergency room with an overdose or with an abscess, right? Or they'll wind up in a jail or prison. So we must make treatment available in all those settings. And the problem is judges and sheriffs who tend to run jails and judges who run drug courts often are not properly educated about addiction treatment. And they have very strong opinions. And there's a very negative attitude about methadone and Suboxone. And I'm very proud to say that New Mexico, you know, it was in 2006 that we made methadone available at the Metropolitan Detention Center. But unfortunately, to this day, it's the only jail in all of New Mexico and none of the prisons that has methadone or Suboxone. So we have a lot of work to do.
All right. Well, we do have a couple more questions in the chat. Why don't I collect all of these questions and we get to them next week? Does that sound like a good plan? Because we're almost done with our time together this evening.
You want to try like one more question?
Okay, you want to do one more? Let's do it. Let's do it. So the next one is methadone a lifetime treatment?
Okay, and I will address that also in more depth next time. But let me say that this is what I say to patients: you should be on methadone at least a year, because it takes at least a year for you, not just. I mean, we can get you stable on medicine in 2 or 3 weeks, maybe a month, but it takes a year at least for people to get the rest of their life back to normal. And having said that, people can decide to discontinue treatment at any time. But I do tell people the truth, which is that 80% of people will relapse within 12 months of discontinuing methadone or Suboxone. Now, again, that sounds like very negative news, but as I said, other chronic diseases we treat with chronic medicine. If I were to stop my cholesterol medicine, what's the chance my cholesterol is going to be shoot up and be abnormal? It's probably 95 or 100%. If I have high blood pressure and I stop my high blood pressure medicine, what's the chance my blood pressure is going to shoot up? It's 100%. It's almost guaranteed. So yes, people need to stay on it as long as they are benefiting and as long as they wish to stay on it. But I encourage people to stay on it as long as they're benefiting, as long as they're doing well, and not to be overly influenced by other people who are saying, oh, that's horrible, you're still a drug addict. No, you're not still a drug addict. No, it's absolutely false. But the stigma has a huge role in impacting people. And again, I'll talk more about that next week.
Excellent, excellent. Well, with that, we are at 7 p.m. Thank you so much, Dr. Trigg, for being with us tonight. Lori posted in the chat that same time next week, we will meet and we will tackle some of these questions that are in the chat and some others that I'm sure will come up throughout the week.
Please come back. You are going to know more, I tell you right now, than most of the people you work with in any professional setting about opioid use disorder treatment, not because people aren't smart, but because people have not been exposed to it. I mean, the amount of time in medical school that I spent on substance use disorder is about equivalent to the last hour and a half we spent. I mean, it has not been part of medical school training, of nursing school training, of social work training, in the past. And this has to change, and it has to change very rapidly. So anyway, it's a real pleasure. Everyone, stay well, and I'll see you next week.
Excellent. Awesome. Thank you so much. All right.
I can't leave. I'm stuck.
Oh dear me.
It was a really good turnout. We had over 50 people.
Oh, were there over 50? Oh, excellent.
Yeah.
Excellent.
And
Is that
so
what you expected?
for us, that's good, right,
Oh, really?
Veronica?
Okay.
So,
Oh yes,
Yeah,
that's an
yeah.
excellent turnout on a Thursday night.
yeah.
That's phenomenal.
Mhm.
I've done 4-hour trainings with 2 people. So
Yeah.
so 50 people are very, very much worth my while. I didn't get as far as I would have hoped to, but I should be able to speed it up next time. But that's good.
Excellent.
It's a good point to divide it between methadone and.
Well, if we go a little over, that should be okay, right, Veronica, next week?
Yeah. Next week we're a little bit more lenient. And I think everyone that shows up tonight will have a better sense of what to expect next week.
Yeah.
So I'm sure that there'll be a little bit more flexibility
Right.
staying a little after if need be. If anything too, what I have done in the past is if we don't get to all the questions, I still will provide you with the questions, Dr. Trigg. And if you want to answer them, and we can put that a part of the package of the
Absolutely. And I'm totally happy giving people my email address if they want to pursue, in depth, questions, and people may have personal questions or, professional or, I'd be happy to.
excellent.
You got many, many thank yous. Much
Yes.
appreciation. Great presentation. Are you looking at the chat?
I didn't look up until now. Usually when I'm on this, I spend a lot of time on.
No, very, very positive feedback.
Yes.
So thank you. See you next week. This is very informative. So there's clearly a lot of interest. There is a lot of interest. I received many, many, many emails from people who couldn't come tonight.
CEUs for the training.
Huh?
Yeah.
Someone's asking about CEUs for the training. I wish there was. Is this
Yeah, well,
after the meeting?
Christina and I are going to talk about doing some follow-ups to this. So Christina was very happy to see the turnout and
yes,
that there clearly is a lot of interest in this.
Oh, I'm thrilled.
Yeah. Yeah, and it's good that the nursing folks showed up.
Yes.
So, yeah.
That was really great.
Yeah.
I will also I didn't think to share this I mean, I shared it with the whole community, our campus, but I'll invite Dr. Flood, who is the director of our nursing program, and let her know that this is the second part is happening, and share today's video. Then
Well, I think